person-centeredness, as far as WHO is concerned, it is really about the two persons in healthcare, and one is a patient and the other one is the healthcare provider. And so when we are discussing patient engagement, it is more of the side of the patient, but we know that any practice is usually goes through the various stages of learning, whether from the knowledge where theory is given up to supporting all the way to application of the same. And so it is our assumption, or rather it is our belief that if patient-centeredness is defined clearly, and learning is able to happen, and so by the time we come to the patient side, the healthcare provider is well prepared. And so that will be our main aspect, but I will do the curtain raiser by talking about patient engagement. And so when we discuss about patient engagement, it's about patient-centeredness, in that we are saying that when a patient comes for care, they say, kindly make sure that I get care that works, that is quality care, whether we are talking of timely care, of care that is evidence-based, of care that is effective and efficient. It is about that you give me something that works at the right time I need it, in that it is the right care to the right patient at the right time, but at the same time, it needs to be safe. So those are the three main aspects of optimal care, and our emphasis today is on patient-centeredness, and patient engagement is a means of having that happen. And so why is patient-centeredness the way that we should be thinking as healthcare providers and doing in terms of how we are providing our health services, both at the level of the hospital, but also at the level of the system? Because when we have a referral, it is going through various aspects of the health system before they arrive to KNH. Even up to that level or to any other referral institution, it is actually the system that is prepared to take care of the patient's needs. So patient-centeredness is at hospital, healthcare provision level, but it goes all the way up to preventive care, giving messages and enabling the patients to be at the center of designing interventions for them at various levels. And so we look at patients as equal partners that will support planning, development, and monitoring of the use of these services that we are offering, or opportunities for prevention. And so this means that patients and families are at the center of decisions, and they're experts. We are working alongside them. So the technical professionals are working with them. We are told that patients, like with chronic care, they stay with their diseases 24/7. So they just come to the hospital for a short time, or they will stay for 3 hours, but they will be seen by the doctor, let's say for 30 minutes. And so that 30 minutes should be cognizant. We should do it in recognizing that this patient lives with this condition. And so they can give us information that helps us get good outcomes. And this can happen in what we call the 4 Ps, at the level of purpose, that we are looking for a meaningful outcome, both for the patient and for the healthcare worker. The healthcare worker may say, I want you to be compliant to your regime, and I want you to complete your medications. But the patient's idea of a good outcome is, I want to be able to walk, I want to function, I want to visit my grandchild, I want to stand up and support my daughter during her wedding. So that is, they would want to go back to functionality and less dependence. So when we are talking about patient-centeredness, we look at the purpose, and it has to be meaningful, not only for the technical aspect, because technically at times some things are reduced to numbers and statistics, but the patients come in with meaningful desires for which they can communicate. Also at the level of the planning, that we are coordinating this recovery together. It is an agreement of, this is how we are coordinating this care plan. And also at practice, that your ideas are going to be incorporated and you are part of the recovery plan. And slowly, by the time you leave the hospital, we have given you the autonomy to do everything that you ought to do to yourself, because we have supported you to learn. For example, those who really need a support, and maybe those who are discharging patients with chronic wounds or with aspects that need support at home, even in palliative care, end-of-life issues. So the plan has to be really incorporate what is the values for this family, what they desire, and what help do they need to meet what they consider to themselves as a meaningful outcome. And it is also a philosophy. We believe this is the right thing to do because it will, at the end of the day, create more satisfaction and meaning, and the patients feeling like they are valued. This slide just enables us to see some of the aspects of patient-centeredness and engagement, in that there is no single definition that is complete. However, each of them brings something in a different angle. And so when you talk about patient-centeredness, the patient experience is what they will go through. And so we'll be able to have even objective and qualitative measures concerning the experience, and not just looking at a patient or a customer satisfaction. They will be looking at aspects of dignity. Were they part of the care, or were they just being done to? Were they part of and involved, or did you just come and do things to them? It is said that even patients who are moribund and the CCU, they desire communication, that, John, I'm going to put at you, I'm fixing a branula, even in that state. Some who've recovered from that state of being semi-conscious, they remember that they feared most when people came by their bed, because at that time, they didn't know what would happen, because nobody said anything. They just had a poke or something being put in their in the orifice somewhere, and they did not anticipate it. So communication is part of how we engage the patient. So this slide just tells us that it is a mix of all this, but the essence is the patient is at the center of their care. I've already mentioned the patient is staying for 24 hours and 7 days with their condition. So they are expert, that is for chronic care. But for this child who's come, who's been born and is having secretions, and they need to be sucked, or they need intervention, that is not the kind you will engage. But we say in healthcare, there are many opportunities that you can engage the patient. For that child, you will give the safety first, you'll do the fasting first, but you'll have to explain to the mother. So there's that level of also engaging of, this was our outcome, and if we go with this care plan, we should be okay, we should settle within this and that time, or we need to upgrade care and get admission to nursery. So even in those situations whereby we do the safe thing first, we will still need to engage the family for the purpose of them being part of this care. And so in patient-centeredness, we do it because this tailors the care to the patient needs, and it just improves the trust they have in the system, and also patients' experiences made better, and the outcomes are actually known to be better when patient-centeredness approaches are employed. And to the staff gain confidence and get job satisfaction. When you do something and you know it is meaningful, it creates value, somebody comes back and says, you really helped me. I didn't understand this. I didn't know that this was palliative care till when you explained to me, and as a family, we are now better prepared. Regardless of the outcome, they are already now aware and prepared, and they're in a better place. So also the population will have confidence in the system, because the system has various players. And this will reduce wastage, in that the right people will have, in that there will be little underuse. And also we will reduce overuse. We won't have people going to services that are, or levels that they shouldn't, but they will get the primary care where it is required. So those are system issues that in Kenya may be difficult to articulate, but the truth is at times we have overuse, and overuse of care costs all of us. It makes the one who needs it most not to have it available, because we have overused elsewhere. And that realm is also taken care of by the insurance. And so care should be organized, managed, and delivered according to patient needs as an essence of patient-centeredness. And so when we talk about engaging patient engagement, the healthcare provider is not only just informing the patient, they are not only providing care to the patient, but they are providing care with the patient understanding these are their needs, and this is how they will support them. These are the options we have, discussions have happened, and they're empowered to continue doing that at home within the means that they can. In that we say this patient who is the professor of their illness and lives in a certain village, how will they take care of their diabetes? And so how do we help them be able to have insulin that is potent between now and the next visit? And so this helps the healthcare system to be responsive to the patient. And when we have patient engagement, we facilitate and support active involvement of the patients in their own care. And we say that patient engagement is an aspect, or it is the hallmark of patient-centeredness, that the patient is not just informed, is not just involved, but they are engaged in looking at that which we call the meaningful purpose. We've been with them at planning. We have empowered them to execute. And when they go at home, they are able to continue being part of the winning team because the outcomes matter to them. And so they easily take up the instructions and the advices they are given. And so the components are that you look at the patient's preferences and you look at the key elements in the team structure to support patient engagement, and you design the care around the patient. And so this could easily be for specific clinics that they'll have specific populations, whether it's orthopedics or it is endocrinology, or we are talking of, let's say, the parents who are having babies in NICU. So how do we support them? How do we design the aspects of care that and have the structure that are around structures are not only in the hospital, they even have family and community support. And there are those that are in the hospital, they are social workers, but they are healthcare providers. Like you could have nutritionists, you could have others that come for mental support, and this is being the team leader, being the doctor. So essentially, those are the key components. I just wanted us to share where a study confirmed that when patients are engaged, when they are actively engaged, we see that when this is reflected in their patients, that only 41% of medical patients believe that their treatment reflects their preferences for palliative care over the more aggressive intervention. Here we are trying to say that the aggressive interventions are for the doctor. They are not, the patient is not at the center. So the patients felt like they were not, they would not have preferred having the aggressive interventions for which the doctors thought is the right thing. As you can see, 71% of the doctors believe that patients have these interventions as top priority. So there is a disconnect. So meaning if we engage the patient, it is likely that the doctors would reduce the number or the intensity of the intervention and suit what the patient's preferences are. So here we were looking at, did we engage patients in how much intense we decided to intervene? Let's say if we decided to do flaps, cosmesis, or we decided to put implants, whatever level of intervention, and this was for palliative care. So maybe the surgeons would tell us what interventions are aggressive for palliative care of breast cancer. But out of this, only 41%. So there's a disconnect, 71 and 41. So the patients would want to be heard and listened to, and maybe less interventions. But that cannot happen if we are not engaging them actively through communication and through sharing the options that are there and family making decisions. And so the essence is that we look at really not what is the matter with you. The matter with you could be the bacteria, the cancer. The matter with you could be the fracture, but what matters to you? So after it is confirmed, technically speaking, you have this stage of breast cancer, and this is the care you're gonna have. We don't just proceed without knowing, okay, as we do this, what options do we have in just unpacking what matters to you? Yeah, what matters to you? Does it matter to you that we, cosmetic-wise, this will be better than the other? Because all these are options and they will not make you not get more advanced cancer or get suboptimal surgery for your tumor, but we're saying what matters to you. If image is what matters to you, then we will consider that. If what matters to you is the shortest stay in hospital, what matters to you is having this care, but coming as a day care, taking care of your child who's at home. So the essence of patient engagement is that we ask what matters, we listen to what matters, and we do what matters to the patient. So essentially, patient engagement enables us to be able to offer care that is meaningful to the patient. It is an aspect or a part of patient-centeredness, but it's very important that we get the skills of doing that. As you see here, it requires listening, it requires value clarification, and it also requires you to then plan. Then you do what matters to the patient. Allow me to stop there. This was supposed to be a curtain raiser for the patient centeredness in training, but just to scope this and tell us that it is important to factor this in our training because it matters to the patient. When we go back to this slide, we can see that there is a disconnect, and so we need to have the conversations and we need to tailor our care, putting the patients and the families at the center of it because they are the ones who use this care. And so we need to project a hopeful future together during the planning of the steps of their care. Thank you very much. Back to Dr. Kalondu.
Okay, thank you very much, Dr. Lydia Okutoi, for that presentation. And I like what you've said about patient engagement and patient-centered care being about purpose, about planning, about practice, and also it being a philosophy. And I can see still from some of the feedback that we've gotten, the people who are being trained on that and others who've not been trained. And most of the feedback we've got is that apart from one person, most of them got their training at the postgraduate level. So that is the next session that we're going to have about training and curriculum. And unfortunately, we are not able to locate our main presenter for that session, but we will have a panelist session and just pick a few people's minds on what can we do different. And this also relates to Dr. Margaret Masharia's question about patient engagement being the backbone of quality healthcare. And she's asking, how else can we do it? Thank you, Dr. Margaret, for that question. And yes, that is part of the answers that we're seeking to have today during this session. And briefly, just before I go through, or just before I start engaging our panelists, it is an ambush, but please bear with me. My question is about the patient journey. And this is to all you participants and the people who are listening. How do you map the patient journey? In your clinic, in your hospital, do you assist this patient to understand the journey that they're going to walk through their treatment process? More so for patients who have chronic illnesses. Do we assist them to understand? And these are the concepts that Dr. Lydia Okutoi has talked about. Do we assist them to understand, for example, a newly diagnosed cancer patient? Do we assist them to understand that this, from the entry point as you come in, this is how your journey will be throughout chemotherapy, radiotherapy, during surgery, and the timelines also, so that they can also be aware and their family can be aware and they can have all the information regarding their disease process with them. I normally see some facilities who refer to KNH patients coming with their files, and that is a very good practice. Same also to the oncology patients from KNH, I see them carrying their files, and a few clinics I see patients carrying their files. I think that is a great practice because the patient can be able to have continuity of care no matter which facility they visit, and they know they have all their results with them, they have all their treatment medication with them. They know what medication they'll be taking, and therefore the next caregiver can be able to understand and see that this is what the patient has been on. So this is just a challenge to us. Whenever a patient comes to us, kindly let's help them have a good process, a good and enjoyable journey. Healthcare is not enjoyable. It might be enjoyable for those of us who practice this, but for the patient, it's a different ballgame. It might be a journey of pain. It might be a journey of stress. It might be a journey of financial stresses to the family, both the nuclear family and the extended family. So we need to walk that journey with them and assist them. And also, as we have technological changes in healthcare, I hope there's somebody in this session who's thinking about how do I make this patient understand their journey using the technological apps that we can develop. I'd be excited to see an app that is able to tell or to show the patient that this is how you go through our system, or this is how you, at the touch of a button, the patient can know how to navigate their processes in the institution. And yes, Dr. Kutai, I agree with you that the patients are equal partners in planning, developing, and monitoring their care. So we need to make sure that we meet their needs. We need to make sure that first, before we meet their needs, that we understand them and we respect them. And I'd like Dr. Kutai to lead us briefly, or just to give me a heads up on how do we handle this next session. Who are the panelists? I'm seeing a few people and I wouldn't like to ambush them. So Dr. Kutai, kindly let me know who I can throw a question to from the panelist section and also from the attendees question. And they're not difficult questions. They're just us brainstorming and finding out how can we do this different? How can we introduce it into a curriculum a bit much earlier, now that most people are saying they got it in their postgraduate, apart from one person who's from Maseno who said they got it in their undergraduate, which is a very good place to start. When you're starting your training, it's a very good place to start. So Dr. Kutai.
Thank you very much. I think we can just have some overview in the opportunities for patient-centeredness in our training in terms of where we are, in terms of, it's like a SWOT, in terms of this is where we are as far as patient-centeredness, and any specific topics or any specific departments, because we don't know where this falls. In medical school, we are more of, we learn by apprenticeship. And so when I see Professor Wanyoro with a patient, just the way he will practice, how he will introduce himself to the mother and examine how he will debrief, I will learn. So I know that is happening, but I would want to hear, Professor Wanyoro is from KU. I can see Dr. Juka from University of Nairobi. And then on maternal health, I would want Dan to talk about the post-service, it's called post-service training, just something about, because there's a lot of quality of care aspects that are being introduced by the Ministry of Health and some standards. Is there any opportunity he's seeing? So to do with the pre-service training, we can get a comment from Dr. Juka and Professor Wanyoro. I can see they're here with us. So if they can be enabled to, at their panelists, so they can unmute. So Dr. Juka, and then Wanyoro.
My name is Dr. Juka, as you have heard. I am a lecturer at the University of Nairobi Department of Surgery. And I want to thank the organizers for giving me the opportunity to share my views on patient-centered care. Of course, as we have been told, is a multidimensional concept which then addresses patients' need for information, views the patient as a whole person, promotes concordance, and enhances the doctor-patient relationship as we know it. In terms of training, as Dr. Kutoy has indicated, because this is a value, is like training students or the professional, the future professional in value, in terms of what you value. More often than not, as we have been told, it's a apprenticeship kind of training. So the students will probably see more of the role models and pick the things that one models rather than what is stated. And of course, then the hidden curriculum, as they say, becomes more powerful than the explicit one. And if you look at the ideas that have been there in terms of what I've talked about, whole person care, and the concept thereof, the idea is even when we are being trained, in undergraduates, taking history, because communication, I think, is the centerpiece of patients' engagement, how we communicate, or whether we communicate at all. And so our training, the basic training for medical interview or patient interview, what we call taking history, as we were trained, more often than not, it was a biomedical based kind of history taking. And we were not really trained to look at the illness model, where we look at patient, what does the patient think is happening to them? And so we were keen to get the diagnosis from our perspective and go ahead and manage that biological diagnosis without looking at the other aspects of the patients. Like we've been told, what do they value? What would be their perspective in this kind of training? And of course, like we've been told, in my view, that is an opportunity for us who are in training. I know for example, myself, there is an opportunity of training which is deductive for the pre-service students. And that training is both in class and also role modeling it in the clinics, in the wards, as you seek to know more about the patients. So I've been told, I think one of the things I would share is there's an opportunity when we train students in taking history, in interacting with patients in the clinic, in class, in the wards, on just how do we practice patient-centeredness? How do we look for, how do we manage the patient as a whole patient, rather than just looking at the biomedical diagnosis and running with it, learning to hear the patients, seek the patient's view and preferences. For a surgeon like me, as I think about taking the patient to theater, informed consent, therefore, will not just say, this is your disease, this is how we are going to manage, but of course, give the patient options, tell them what those options would mean, and get the opportunity to do health promotion and health education at that time, and just seek to empathize with the patient, understand their situation, their perspective, their feeling, and communicate that I really understand that. And I probably need to demonstrate that to the pre-service students and the in-service students who are the specialists in training. I think that's what would be my input for now. I would be available for questions.
Thank you very much, Daktari. Yeah, indeed, the initial model whereby it was paternalistic and the doctor knew what they needed to do, and that is all they were to do is gone. Now, healthcare is provided in teams, and also the patient is a partner, and we are interested in them feeling responded to and responsive. And so thank you for sharing in terms of us looking at a patient as a whole and not just the disease. We are not just hitting the bacteria with antibiotics, but there is this Mama Mboga or this professor who happens to be our patient. And so there are perspectives that we consider for the whole person, just addressing their need, but at the same time, ensuring that we are giving quality of care. And where there's variance, we are able to come to an agreement because it is care that is co-planned whenever possible. I don't know whether Professor Wanyoro is able to say something and also just comment about any possibilities of patient-centeredness and quality of care. I mean, is it infused in the training and in the assessment, or is it something that needs to be addressed also as a separate entity, or is it sufficiently infused in our training curriculum? I don't know whether Professor is with us.
Yeah, I am, Lydia. Thank you very much for giving me this opportunity. So what I would want to say is that patient-centered care and of course quality of care is one of the areas that is lacking and is very essential in our pre-service training. And you find that probably this is one of the soft skills that should be brought forth and be put in the mainstream, like for all the students that we are training, even if it is like to have a unit that looks at patient-centered, and I look at patient and family-centered care, because when you have a patient, it is very hard to leave the family out. So I think it's an area that is lacking, and we need to think of the whole patient plus the family in their care so that they are able to participate in the care itself and learn with us as we manage their care. At the same time, I believe that, of course, most of the times as clinicians, we look at the outcomes. We look at a patient comes to us and it's a mother who has come for delivery. And then we look at, has the mother delivered, has she gone home with the baby? But now we are looking at more of the patient experience during that episode, or during that time that we have had with the patient. What was the experience that the patient had? Was it respectful enough, or did we have some disrespect as we manage that mother or that gynae patient who came to us? So I think, of course, there has been some retro attempt through mentorship of students, but you see, mentorship is also another area that is also not well infused within our curriculum. So this looks like, of course, when we talk about patient and family-centered care, it looks like basically it is individualistic. So it's an individual doctor who decides that I'm going to try and infuse in the students that I come with issues to do with patients and family-centered care, as well as quality improvement, without having it being in the mainstream of curriculum. But I think we should have this as a unit in our curricula that is related to the care of a patient in a hospital. Thank you.
Thank you very much, Professor. what we are hearing is that there are needs and there are gaps to do with the training. You say that actually we are able to see it being demonstrated, and so in demonstration, we cannot be sure whether it is consistent. We can't be sure that all the students are just exposed to that level of demonstration. There could be opportunities of outlier, but I can see that in your normal curricula for obstetrics, for example, taking care and normal delivery, you will be able to train us on the knowledge that is there. Like we'll go through the didactics, and you'll enable us having these scientific bases and theories to understand that this is how it works in a normal labor. And later on, and so after understanding this is how it applies when things are abnormal, or this is how it applies when you're to conduct a normal delivery. So there's what is called the Bloom's taxonomy of learning that I need to remember, to understand, and to apply, to analyze, and even to evaluate. And so I can see that patient-centeredness from your sentiment, it appears that quality of care and patient-centeredness may not have all those aspects. And so there's a possibility that we need to have some affirmative action towards it and situate it somewhere in terms of how these will be taught. In KU, where do you think there are opportunities, especially for the pre-service, of this being embedded? Because I remember some courses, even in obstetrics, would say that we have modules for aspects. The modules were never, the modular trainings just had an independent course that was not like examinable for your general passing, because they were not like part of the main curricula. But many aspects got in through modular training. I don't know in KU where you think there are opportunities of having patient-centeredness and quality of care, and that involves aspects of leadership, communication, what you call soft skills. The surgeons have a course they call non-technical skills. It's about communication, teamwork, dynamics, and they even do up to simulations. When things go wrong, how do you respond? How do you respond to an emergency? And it is all an aspect that they're trying to bridge gaps that are in their basic syllabus. So I don't know in KU, let's say for the undergraduates in medicine, do you think it can, where have you people been envisioning these non-technical skills belong before you release doctors? And that similar question will also go to Dr. Juka, in case there are any thoughts in that regard.
Yeah, you see, like, the graduate, most of the students will undergo some form of training in communication skills. But what we are saying is that this is, in most of the times, being an examinable topic, that many of the students do not see the value in probably learning some of these things. And I think if we are to make a lot of sense and probably for students really to benefit from something like patient-centered care, I think it will be good if we mainstream it within our curricula, so that from the first year of training all the way to the 6th year, at least something is handled and on issues to do with the patient-centered care as well as quality improvement. That is my thinking. Thank you.
Thank you very much. That makes sense that it will be actually seen throughout. That means when I'm addressing a mother, it will be very clear who is in labor. When I'm having an oncology pediatric patient, yeah, so mainstreaming, I think, is great. Dr. Juka, let's hear your comments on the same question.
Sorry, my internet was on and off. Could you just repeat the question? Hello?
Hello, Dr. Juka. It seems Dr. Videoctory. Hello.
Hello.
Yes, Dr. Juka. It seems Dr.
My
Video
internet was on and off. Could you repeat?
She's back. Dr. Lee, doctor, could you please repeat the question for Dr.
Great. Yes. So my question was, given that there is a gap in how these non-technical skills are trained through, because some people may have affirmative action. For example, the surgeons, you have non-technical training. It's called non-technical skills training. That is, it matters communication, matters teamwork, matters even debriefing. How do you break bad news? And how do you do simulations? For example, in ATLS and such, you use such skills for the purpose of just responding. And so I think routinely we are trained as one person, as one specialty, but we work with the physiotherapists, the nutritionists, and everybody contributes with the health information. And so we're just thinking, as far as the undergraduates are concerned, where are the opportunities of putting these trainings, especially for the doctors? Because in my assessment, I think nurses do a little better as far as leadership and teamwork and communication is concerned. But our main interests are in these undergraduate medical students, the MBCHB and the likes. What are the thinking of the departments and the schools with regard to the gap of not only just us seeing patient-centeredness being practiced, but having through that they will be given something to remember in terms of knowledge. They will be made to understand through practice and other trainings, and all the way up to applying that knowledge, and if possible, examinable. Yeah. Okay.
So I get you. I think for the pre-service students, what is needed is, like the communication skills that is being taught. And I think that is not just in our part of the world. I think as recent as 2015, there's been some issues to do with how communication skills are being taught even in Nordic countries. And so what we do actually, communication skills that is supposed to be teaching the students how to communicate with one another, but also how to communicate with patients, is usually taught in year one. And so by the time they come to clinical areas, they find, and what they find as the culture therein is the way we take history that then leaves the patient-centeredness out completely. So I think what should be done for pre-service is a situation where curriculum change that then puts that communication skill in the current form, like I was saying, the current form that requires an illness perspective and not just the biomedical perspective that includes the biopsychosocial model, the whole person model, a way of taking history that is inclusive. I think that curriculum should be put in the clinical area. That is one, in terms of communication skill, or what you'd call medical interviewing skills. So a change of curriculum that puts that in the clinical years, but also role modeling, so that when I am in the clinic with the students, I don't just help them look at the biomedical model of diagnosing a patient, but look at the whole patient. And then, of course, as you say, in the current age where we are doing OSCEs looks at the competencies. And one of the competencies that we look at, of course, is the history-taking competency. And so in our assessment, we also need to include the patient-centered aspects of history-taking, so that we don't just focus that assessment of history in the biomedical field. So if we assess it, we role model it, we put it in the curriculum for didactic teachings, I think we will be helping the pre-service healthcare worker. And as you say, the in-service healthcare workers, there are opportunities of workshop, of seminars, of a number of training that happens in terms of their communication like you have indicated, I think for surgeons, there are non-technical skills training curricula that are out there that could be used to help them. Thank you.
Thank you, Dr. Juka, for the comments. Indeed, they are very valid and pregnant. We hope that come 2 years from now, we will hear of some progress. Yeah, yourself and Dr. Wanyoro, Professor Wanyoro, you've confirmed that there is a lot of action as far as this is concerned, but there are gaps and which can be addressed. And a curriculum will mean that we are committing ourselves to having this be how we will train. So we look forward for that being infused in the pre-service and even the post-service for the purpose of the postgraduate students. I don't know whether Dr. Okoro is still with us, but there's been a lot of movement in the side of maternal health in terms of training about communication and at the same time, even addressing STIs. How do we offer care that is person-centered for the adolescent, discussing about family planning options. There's a lot of communication in it because most of the time there's a bargaining between family, husband-wife relationships. And so it is something that the healthcare worker does not just come and dictate, but it is a conversation that requires to have actually that patient at the center of it for the purpose of optimizing the technology that is there, either to have planned parenthood or also in terms of even options of delivery and such. And people nowadays also come with a lot of opinions. So I don't know whether Dan Okoro is still there. He could just give a comment. Dan works with the UNFPA. Is Dr. Okoro with us still?
Yes, thank you. Lydia, are you hearing me? Are you hearing me?
Yes, Dan, we can hear you.
Oh, okay, thank you. Yes, I'll have just about 2 minutes. I'm joining another meeting at 3. But thanks a lot, and think for the background, and thanks for the presentation and the comments made on the wall, and even from Professor Wanyoro and Dr. Juba on this subject. And it has become one of these main things that we're looking at currently. And indeed, as you have rightly put it, great strides have been made, especially looking at the maternal health. And many times, I think, over the last 5 years or so, or if not a decade, in what we call the woman-centered care, which has been progressing well. And it is for one reason that even WHO released about 4 years ago, what we currently call the post-pregnancy experience for better outcomes of maternal health, the 8 contacts, including 8 contacts. So that it's not just like Dr. Jukas mentioned, it's not just looking at the biomedical aspects. And many of us, we know that pregnancy is not a disease as such, but more like condition which has got experiences, and people look at the quality of care. A few years ago, it could be a few years, there was a report which came out and that gave birth to what we now have, the respectful maternity care. And this has subsequently global WHO guidelines on maternal newborn health, the standards of care that has been adopted by the Ministry of Health. And I believe some of the counties may have had orientation or capacity building on the same. And this has been integrated within the Ministry of Health under the Kenya quality of care of health, so that we look at the mothers, wherever side that come with the MCH and family planning clinic. And like the components that you mentioned, that even a moribund patient has got some sense and has got an experience. And many in the maternal health and even the use of perinatal health speak to the babies, speak to the newborns. And it's not that the newborns are hearing, okay, it's not that there's a sense that we know that they do hear as we speak to them, but we know that we don't expect them to respond. But I think that kind of nurturing helps us also to extend this and broaden it into other aspects of care for our clients wherever they are. And no wonder for over years ago, the TBS have been doing much better, traditional birth attendants. Why? Because for us, we were concentrated more on the diagnosis and treating and saying with these kind of skills that I have, with the knowledge that I have. But the TBS, we still find, even right now, I think some of the regions, probably they have a sizable number of mothers still being attended to the TB, traditional birth attendants, not because the facility is not there, but what they call quality of care is not being observed or not being provided in those facilities. It's because maybe those traditional birth attendants and even and other cadres do provide better, what they call better care than them, despite the fact that sometimes they come with complications. But to that client, it is that kind of care that they would wish to see. And speaking of which, it is sometimes, even in certain towns or the rest, sometimes there will be this comparison that is being made. While I may be an obstetrician gynecologist, but there is a colleague or another healthcare worker who is maybe a midwife or could be a clinical officer. But the clinics are full because they attract more patients, because the way they talk, the way they handle their patients, speak to the hearts of those clients. With my distinction in any field that I have, but I may not be so much in terms of providing the client-centered care. And suffice to say that while we look at the pre-service, this pre-service would be healthcare providers, when they finish, they practice or they learn in institutions. They could be level 5, could be level 6 facilities, or even where they'll be sent for any practical. Unless that working environment as institutionalized patient-centered care, even if we train them, we put it in a classroom setup, but the working environment should also have that, should also practice the patient-centered care, because otherwise then we'll have it like an exam of kind of, or it would be just for theoretical to satisfy the examiner and then get on. But when you go to the institution where they're going to practice this, then they have a challenge. So let's try to institutionalize. It is doable. We have come a long way, and there's been good progress, and we still look forward to this. And we will take note that patients also have rights, and right now you may be doing what you think is okay, but to that client, if they feel that their rights are not being observed or being upheld, then we have a challenge, and they can be sued. And that we don't want to go to that particular area. So thanks a lot for the session, and we look forward to better care for our clients and even for ourselves, because we look also to see that what I would receive is what I should also give to another client, to the client who I'm caring. Thank you so much, and I'll be out now.
Thank you very much, Dr. Okoro, and thank you, Prof. Wanyoro and Dr. Ojuka. Yeah, indeed, these three panelists, they joined the panel a few minutes ago, and we've really done justice to the topic, and we pray that these efforts will bear much, both now and for the generation to come. And thank you as even you join the other meeting. So as we come to a close, I think I will ask Rhoda to see if there are any questions that needs to be responded to in the chat, in the question and answer, or in the chat, in case there are anything you think needs to be responded to, and even what you can or any of the panelists can do so. Thank you.
Okay, thank you very much, Dr. Lydia Gray, and thank you for moderating that session. Thank you, Professor Wanyoro, Dr. Daniel Ojuka, and Dr. Dan Okoro for accepting to be ambushed and for doing it justice to the topic. From what I heard from the three panelists, I'll just give a brief summary before we go to the questions and to the comments in the chat, is that there is need to role model. There is need to have it as a transferable skill. This patient-centered care, you have to demonstrate it so that the student can learn it from you. There's need to teach the students both in curriculum and also in practice, that we need to learn to hear the patient and see the patient as a whole. There's need to demonstrate it in pre-service, in-service, and post-service at all levels, and that it is a soft skill that is necessary. This was from Professor Wanyoro, and that there's a gap in our training and also to some extent in research. There's also need for us to focus not just on the patient outcomes, but the patient's experience in their journey in your facility or in your institution or in your clinic. And there's need for us to structure the mentorship process that we have. It is not, as Professor Anyoro has highlighted, it is not well inculcated in our curriculum and not well documented. So mentorship has to have some sort of structure. And at the moment, as was highlighted, is that patient-centered care is individualistic. It is what you as a doctor, you're doing, it's not standardized across board. And we also learned about communication skills and the culture that we are passing on to the ones that are watching, the ones that are learning from us. So I've seen the few comments, and briefly just before I go to that, some food for thought. We have talked about redesigning the curriculum to incorporate patient-centered care in our pre-service training. And I think one thing that's very clear, because I'm just looking at the comments and I'm seeing a few definitions here, that we need to have clarity on how do we define patient-centered care in our context, so that we're having a standardized definition. This is how we define it in our healthcare system in Kenya. We need to know how to assess it. We need to also understand what are the competence levels that we want to see, or the skills, and how do we assess these skills. When you look at the patient-centered care principles, how do we assess respect for patients' needs? How do we assess information sharing? How do we assess coordination of care? And also, how do we ensure that we have consistency across board, so that what is taught in Maseno is taught in KU, or it's almost similar, and it's what is in MKU, it's what is in University of Nairobi, it's what is in KMTC, it's what is in Baraton, it's what is across all the universities that we have across, so that whenever this student is posted after their pre-service training, they're able to practice it to the best of their knowledge. So quickly through the comment and session, the chats, there's a question about, there's a comment from Virginia who talked about patient and family-centered care included in pediatric nurse training. And she said that's where she first got the concept. And she made a comment that unfortunately its implementation varies in practice, as we play a major role on how we engage the patient and family. It may be easier to implement with families of children as you have a well parent who can be enabled and empowered to be part of their child's care. And she agrees that it's quite vital in training. Lynette McCory is also agreeing that we need to look at the patient as a whole and not as per speciality. And there's also feedback from Zainab, who talked about patient-centered care, starting from the reception, while you're going through the admission process, where there's evaluation by the nurse, nutritionists taking in mind comfort that the patient has. And then when you get to the doctor's level, there's need to explain the disease, the family involvement and counseling, and the quality of care that can be given to the patient, both at the hospital and at home. And she agrees it is a multidisciplinary and teamwork effort. And Maurice asked, how does patient-centeredness vary across the medical disciplines and across time? And he gave an example of psychiatric and drug-addicted patients may not be able to make firm and fair decisions about their care. And Maurice, this is where we talked about family involvement. So let me quickly just go through the questions. I'm seeing we have a question from Benta. And Dr. Okutori, maybe you could take this first one. And Benta is asking, are there opportunities for developing patient and family advocacy teams in the hospitals in patient and family engagement? I think that's forums, I think. Is there opportunity for us to have advocacy programs in our institutions?
Yeah, I think there are opportunities and institutions. There are some programs, even cancer care programs that are now like NGOs that began as patient advocacy team. But when their interests became beyond the hospital and they were registered as a profit, as a non-profit, it became a little conflicting. So there are such teams, but I think the owners are now on the institutions in terms of it is institutions to have structures that they can engage patients and families. For example, in our dreams at KNH, we have many dreams, but there are some that have come to pass. For example, there is a support group for, what is it called? For colostomy. Yeah, because at times when you have a permanent or temporary colostomy, it is a life-changing episode. And so if you need support and even just where to source the bags. There was a time there was shortage in the country, and so they would be having well-wishers and importing the hospital through the palliative program and such. So I think there are opportunities for that. Think about even just the patients who have relatives who have their patients in the critical care. It would be good to have a support group. Then the oncology patients have had some support groups on and off. I think there's some activities that are upcoming. And there are other groups that are beyond hospitals. They are just like for sickle cell. There are some that are within the institution, some that are without the institution. But I think every institution should look at their various groups of patients and see do these need support. For example, mothers in the newborn unit, and even the fathers who have their children in the newborn unit. So the structures of engaging and to ensure that the patients who come and benefit from these are not at risk, because it is not being run fully by the hospital, but you'd want to give a structure and the families and patients to form a peer support. So the structures are the ones that need to be worked on, just because, let me not say because we are Kenyans, but there are times that people go beyond their mandate and the other patients who come are at risk. But in the spirit of trust, because the essence of patient-centeredness is you're establishing trust. Yeah, in the spirit of trust, I think there are things that we should dare continue engaging and put structures for the same. In HIV care, the PMTCT option B had the aspect of peer support, and peer support has made a great difference both for the youth, adolescents with HIV, and even for the mothers to prevent transmission of mother to child, just for them to know you can take care of your baby in this way, you can take this medication, and it will reduce the chance of your baby being exposed. So we've had best case studies, but we have not done it as often as we should, and we have not maintained them. Some come and they disappear when the people who are very active come and go, but it is opportunity for all institutions to do that. Thank you.
Okay, thank you very much, Dr. Toy, comment. And yes, there is room to have patient advocacy groups within our institution or within our hospitals. And yes, I do agree with you, Benta. If the healthcare workers are involved or they get feedback from the advocacy groups, it would add value in the training, especially pre-service classes. And from Robinson Duarte, he's saying the internship program for healthcare providers should introduce patient communication as an examinable skill and incorporate mentorship by supervisors. Dr. Janet Ojuka, is this possible? Is it possible to examine soft skills? We've talked about curriculum and the gap that is there in the curriculum, but at the internship level, is it possible to examine that?
Thanks for the question. I think those are good questions. I think the main issue, like I was suggesting, for example, communication skills. For OSCE, for example, you are in the same room with a standard patient or a real patient and the student. So you hear the interaction, you see the interaction, you observe. So it is possible to assess But I think the best way of training is a way of doing that even before exam and then giving feedback. Because I think that is feedback is a very good way of training, and then you lead the students through what you call a debrief of how they did, what they can improve, just a reflection. So it is possible to assess it, especially in an objective structured competency examination, where you are together with the patient and student. But in the traditional long case, short cases, it's difficult to assess that. So my view would be have a way of not just the summative way of during the OSCE, because that can help in assessment, but in the teaching, apart from role modeling, also probably have sessions or workshops with students where you give them standard patients and then give them feedback so that they can reflect and improve on some of those things.
Okay, thank you very much. And one thing we appreciate about internship, because it's the first point immediately after pre-service training, especially in healthcare training, is that it's a place for learning your skills. And we may not have the opportunity to fine-tune your skills. It's also a place to get mentorship, to get your experience, to get more training in that, in medical cases. And therefore, I agree with the previous comments that it should start at the pre-service training. At the internship part, it might be a bit too late to introduce it. If we could introduce communication a bit earlier, communication skills, patient-centered care earlier, it would.
Dr. Rhoda.
Yes.
Sorry for cutting you. I think if one of our my developing view is that we have not taken internship as a training level. More often than not, if you look at the way we treat interns, I think they are more often workers. So in terms of giving them feedback, I think we more or less have very few of that in our facilities. And so I think that is one of the things that we probably could change in terms of just developing sessions for these interns to learn some of these few things, so that we because I think we forget that they are students, or rather they are still under training, and then we treat them just as we treat doctors, which is not bad in itself, but I think one of the things we need to remember is that they are still under training, and some of those skills they have not probably got, and they are not proficient in any of the skills, whether technical or non-technical. So my view, I think it is possible to develop because I think I have seen some of the mission hospitals develop for them some of the sessions where they could get technical skills, but also we could also just help them get non-technical skills in the same vein.
Great. Thank you very much. There's a comment from Lucy about addressing issues of patient-centeredness in public hospitals. Yes, Lucy, this is what we are talking about. And it is a responsibility for both you and me and everyone else in the healthcare field to change our culture as it has been. And I'm seeing part of KU is saying that they are doing something actively on that. Nelson, could you enable Dr. Masasabi to just tell us briefly about this module on ethics and law? Just briefly. Nelson? It's good to learn from what KU is doing and how we can do it different. So Nelson, if you're available, kindly enable Dr. Masasabi to just briefly tell us about this medical ethics and law module, whether it's examinable, and how they started it and what necessitated the need for that. But I'm seeing the topics that is put there on doctor-patient relationship, quality assurance, patients' rights, and shared decision-making are very, very good topics that we need to embrace. And as we wait for Nelson, Dr. Chokwe is saying that the challenges of matching workload of trainers and the mentees must be addressed. Yes, that's true. In the absence of Dr. Masasabi, maybe Professor Wanyoro could briefly comment on that particular curriculum and the module.
Well, before I comment on that, of course, medical ethics is another topic that is very important. And in this era, we are also thinking that, of course, for our students and for clinicians and, of course, medical personnel, we have to look at everything ethics and also the issue of the law as we are taking care of the patients. But what we are talking about today is the issue of the patient-centeredness. And what I think, there are many areas that you will find are essential in medicine, including, of course, ethics and including the legal aspect of practice of medicine, the patient-centeredness, mentorship, etc. And what I think is that these issues can be handled like when universities and, of course, the colleges, the tertiary colleges, are looking at probably the global curriculum. This should be looked into, and then we see how to infuse in the curricula in the various level of training. But what I wanted to say as a final shot is probably that when we look at patient-centeredness, it should be like a culture. Like when I see a patient, I think even if it's like in an office or in a clinic, let's say I'm a midwife, I'm running the family planning clinic, then I think of what that patient experience will be from the time that patient comes all the way to the time the patient goes home. And I look at this as teamwork, because we may have one level of staff practicing, but you find the other level is not practicing. And if we can be able to infuse this one in every person who is taking care of the patient, from the clinician to the non-clinical staff who may come across this patient, and we infuse this culture of patient-centeredness and have it as teamwork, then we may succeed even where it seems to be lacking in our public health facilities. Thank you.
Thank you very much, Professor Wanyoro, and thank you for that response. Yes, I agree with you. Patient-centered care is a culture that we need to inculcate in our facilities. And thank you for that response. I'm seeing from Caroline Okoth, she's saying that examination of soft skills is possible. Department of Clinical Medicine and Therapeutics does this. as one of the stations in the short case exams. That's at postgraduate level, I think. This can be done at undergraduate and postgraduate. This will allow the students to practice what they've learned in class. Thank you, Dr. Koth, for that feedback. And yes, that should be introduced and we should find ways of passing on this culture to the new doctors. As somebody had said, the younger doctors. I don't think they're young, but they are starting fresh in the system. So we need to teach them the best practices as they come into the system and live good, lead by example, role modeling. From John, he says individual healthcare facilities also need to capacity build their staff on patient-centered care and carry out regular customer satisfaction surveys and exit interviews. Thank you, John, for that feedback. And I agree with you, patient-centered care needs to be, resensitization on patient-centered care needs to happen frequently to the staff who are in healthcare facilities, and that we also need to look at not just the customer satisfaction, but the patient satisfaction and the patient experience. Remember, we talked about patient experience, not the outcomes. So the experience in their journey within your institution, within your facility, what was the experience as they moved along that? And any other? Yes, from Dr. Kizito Lubano, he says cultural competence and context is extremely important. He's agreeing with Professor Onyoro. So Dr. Kutwai, if there's no other comment, I think you could wrap this up for us.
Yeah, thank you very much for attending. I think this was a very important topic, and from the comments, I think we need to engage much more. Just to pick up from a comment that came from Dr. Okoro about, yes, we are, today our focus was on training, pre-service, in-service, and even post-service training. The idea that he brought up was we need to have enabling environment for these patient-centered care to happen. And as we know, all the WHO building blocks are part of the support. For example, physical comfort, ensuring that there is no pain is part of patient-centeredness. That when I came after an accident, my problem was pain. So if there was no painkiller, that is to do with the medicines and commodities in the WHO building block, ensuring there are enough staff. If I have only two nurses for 30 mothers in labor, then even if they want to offer the patient-centered care, it is a challenge. So I think the environment is very important when you look at the building blocks, but also just the aspects that this is how we do what we do. This is our culture. And also we have other aspects that enable us to continually remind ourselves, are we doing the right thing? For example, acknowledging that as an institution, you need a standard. Okoro mentioned about the various standards on maternal care that have been developed. Those were in ISO, those were in safe care. So having such structures, they change the environment that it becomes mandatory at some point. We have to look, what were the complaints? Did you respond to them? And was that effective? And so I think my parting shot is that we create an enabling environment, because if the students learn in environments where patient-centeredness cannot be done for one reason or another, because it has various aspects beyond the listening and being empathetic, also to have the tools and the means to ensure that I've responded to the need of the patient, then it is a challenge. So from our side as healthcare providers and from the KNH hospital side, I think we commit ourselves to continue creating an enabling environment for that to happen. And we hope that that environment will also inspire the training for these healthcare workers, that they get the knowledge about it and the opportunities to apply and practice patient-centeredness. And we hold each other to account by being the one who is able to demonstrate it and to role model it, even to those who are upcoming. So it was a pleasure being part of this, and we will continue ensuring that we do listen and we care as we offer healthcare at Kenyatta National Hospital. Thank you.
Okay, thank you very much. And thank you, Dr. Tu, for those parting shots. I'd like to thank all the participants for attending this session, all the panelists. Thank you very much. Thank you, thank you, thank you. So with that, we'd like to end this session. Have a good afternoon. And there on the timetable is tomorrow's session. So kindly join in tomorrow for our session on eliminating mother to child transmission. Thank you very much. Have a good afternoon. Bye.